Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent education grant from Beatrice.
This program is presented by Medscape Education Global.
Hello, I'm Amina Rakisheva, a cardiologist and a heart failure specialist with a strong focus on advancing patient-centered, evidence-based cardiovascular care. I have extensive experience in clinical research, including the design and implementation of registries and translational studies addressing LPA small, sex-specific cardiovascular care, and complex heart failure phenotypes. My work integrates real-world data with guideline-directed strategies to improve outcomes across diverse populations. In parallel, I remain deeply committed to bedside care, managing patients with acute and chronic heart failure across the full spectrum, from early diagnosis to optimization of disease-modifying therapies to advanced and multidisciplinary management. Welcome this educational activity. The science of SGLT1 and SGLT2 unpacking dual inhibition for heart failure. We've all seen how SGLT2 inhibitors have transformed heart failure care. But here's a question we're exploring today. What if we could go further? Emergency evidence points to SGLT1, a transporter expressed not only in the kidney, but also in the heart and intestine, as a key player in heart failure. Unlike SGLT2, SGLT1 is upregulated in failing myocardium, influencing sodium handling and oxidative stress. This has sparked interest in dual SGLT1 and 2 inhibition as a more comprehensive approach, combining the hemodynamic benefits of SGLT2 blockade with direct cardiac and gut effects via SGLT1. Today, I will explore the physiological rationale behind dual inhibition and discuss what this means for future of heart failure therapy. We have all witnessed the transformative impact of SGLT2 inhibitors in heart failure. These agents consistently reduce cardiovascular deaths and heart failure hospitalization, independent of diabetes status. However, while SGLT2 inhibitors primarily act in the kidney, emerging evidence suggests that a transporter SGLT1 may play a biologically meaningful role in heart failure. Unlike SGLT2, SGLT1 is not confined to the kidney. It's expressed in the intestine and, importantly, in cardiomyocytes. Furthermore, experimental data suggests that SGLT1 expression is upregulated in failing myocardium. This raises a compelling hypothesis. If SGLT1 contributes to sodium handling and oxidative stress in the failing heart, could targeting it provide additional therapeutic benefit? To understand the rationale for dual inhibition, we must think in system terms. SGLT2 located in early proximal tubule, high capacity, low affinity transporter, responsible for 90% of glucose reabsorption. SGLT2 inhibition primarily induces renal glucose excretion and natriuresis, leading to osmotic diuresis, plasma volume contraction, and favorable hemodynamic changes. SGLT1 inhibition, however, lay at 3 distinct layers: located in intestine, high affinity, low capacity transporter, responsible for remaining 10% of renal glucose reabsorption, additional renal sodium glucose transport effect in F3 segment, potential direct myocardial effects, particularly related to sodium influx and oxidative stress. Therefore, dual inhibition represents a broader cardiometabolic strategy, integrating renal, intestinal, and cardiac pathways. The developing of SGLT2 inhibition begins in the early 20s as a novel strategy to improve glycemic control in type 2 diabetes. Physiologically, the kidney filters approximately 180 grams of glucose daily. About 90% of this reabsorbed in the early proximal tubule by SGLT2. By blocking SGLT2, we reduce glucose reabsorption, promote glucosuria, and induce osmotic diuretics. Initially, this was seen as purely a metabolic intervention. Currently, multiple landmark trials demonstrated consistent cardiovascular benefit, reduced hospitalization for heart failure, reduced cardiovascular deaths, rapid onset of benefit, effect independent of diabetes status. Importantly, the reduction in heart failure hospitalization was observed early, often within weeks of initiation, suggesting mechanisms beyond long-term atherosclerotic modification. This pattern strongly supports hemodynamic and cellular mechanisms rather than glycemic control alone. Let us examine the mechanisms in greater detail. First, hemodynamic effects. SGLT2 inhibition reduces plasma volume and interstitial fluid, lowering preload and afterload. Second, myocardial energetics. There is a shift towards ketone utilization, which may be a more oxygen-efficient substrate for the failing myocardium. Third, cellular sodium handling. SGLT2 inhibition indirectly reduces activity of sodium-hydrogen exchanger, NHE1, lowering intracellular sodium and secondary calcium overload. Fourth, structural remodeling. Reduction in LV mass, fibrosis, and inflammation have been observed, contributing to improved ventricular compliance and diastolic function. These mechanisms converge to produce meaningful clinical outcomes. Therefore, clinically, these mechanistic effects translate into lower NT-proBNP levels, fewer hospitalizations, improved symptoms, improved renal trajectory, early post-discharge benefit. Importantly, SGLT2 inhibitors are now considered foundational therapy in heart failure, not adjunctive therapy. This cardiac expression is the most intriguing aspect for heart failure therapy. Looking at the drugs shown, these drugs have different selectivity for SGLT2 and SGLT1. Therefore, clinically greater SGLT2 selectivity means more kidney-specific glucose lowering with minimal intestinal SGLT1 effects. Agents with a lower selectivity, such as sotagliflozin, may have additional effects in the gut, potentially influencing postprandial glucose levels, but also increasing the likelihood of gastrointestinal side effects. In summary, while all these agents inhibit SGLT2 to promote glucosuria and lower blood glucose, their degree of SGLT1 inhibition varies and may influence both efficacy and side effect profiles. SGLT2 inhibitors have revolutionized heart failure care, but they're only half the story. Means the SGLT1 expressed in the kidney, heart, and gut, this transporter may hold the key to even greater cardiovascular protection. Let's compare where these two transporters work and what they do. In the kidney, SGLT2 does the heavy lifting. Located in the early proximal tubule, it's a high-capacity transporter responsible for reabsorbing about 90% of filtered glucose. When inhibited, SGLT2 transporters reduce intraglomerular pressure by afferent arterial constriction, increase glucose and sodium excretion, and decrease preload and afterload and congestion, resulting in reduced hospitalizations for heart failure and cardiovascular death. But SGLT1 works downstream. In the late proximal tubule, it fine-tunes glucose and sodium reabsorption. When SGLT2 is blocked, SGLT1 continues to reabsorb glucose, which is why dual inhibition may offer more complete blockade. SGLT1 inhibition also reduces sodium-hydrogen exchange, adding a natriuretic effect. Here where it gets interesting. Unlike SGLT2, SGLT1 is expressed directly in the heart and it's upregulated in the failing myocardium. Inhibition of SGLT1 may reduce reactive oxygen species, protect against ischemic reperfusion injury, improve mitochondrial function via SIRT1, PGC1 alpha, TGF21 pathways. This means potential direct cardiac protection, something SGLT2 inhibition alone cannot offer. In the gut, SGLT1 absorbs glucose and galactose. Inhibiting it delays glucose absorption, which may trigger GLP-1 release, offering indirect cardiovascular benefit. There's even emerging evidence that SGLT1 inhibition influences the gut microbiome and reduces platelet aggregation. So why dual inhibition? Because SGLT2 and SGLT1 are complementary, not redundant. SGLT2 inhibition delivers hemodynamic unloading and renal protection. SGLT1 inhibition adds direct cardiac effects, gut-mediated benefits, and more complete renal sodium and glucose handling. Together, they offer a multi-organ approach to cardiovascular protection. With the first dual SGLT1 and 2 inhibitor already approved in some markets and more agents in development, dual inhibition represents the next frontier in heart failure care. By targeting both transporters, we may finally address the full spectrum of cardiorenal and metabolic dysfunction. As we look toward 2026 and beyond, heart failure management is structured around foundational quadrivalent therapy. And here we're talking about ARNI, beta blocker, MRA, and SGLT2 inhibitors. These therapies are initiated early and rapidly. Importantly, SGLT2 inhibitors now have evidence across heart failure with reduced ejection fraction, heart failure with mildly reduced ejection fraction, and heart failure with preserved ejection fraction. While ejection fraction still matters, mechanistic therapy is increasingly ejection fraction spectrum based. If we look for the spectrum of clinical indication of SGLT2 inhibitors, we have to talk about heart failure, but also we're talking about type 2 diabetes and chronic kidney disease. And of course, SGLT2 inhibitors are efficient in all these entities. And all of them are entered to the key guideline recommendation. SOLOIST worsening heart failure trial. This trial evaluated sotagliflozin, a dual SGLT1 and SGLT2 inhibitors in patients with type 2 diabetes and recent heart failure decompensation. Importantly, therapy was initiated in hospital or shortly after discharge. Approximately 75% had ejection fraction below 50, but benefit was consistent across ejection fraction strata. There was a significant reduction in total cardiovascular deaths and heart failure events. This provides proof of concept that dual inhibition may be particularly beneficial in the vulnerable post-hospitalization phase. Heart failure is not a static disease. It is continuum marked by a period of stability and decompensation. Modern trials now span chronic stable heart failure, recent acute heart failure, immediate post-discharge period. SGLT2 inhibition demonstrates benefit across this continuum, reinforcing the importance of early and sustained intervention. Event rates are highest immediately after hospitalization. This period represents heightened neurohormonal activation, increased congestion, elevated inflammatory state, increased metabolic stress. Dual inhibition may be particularly relevant in this vulnerable window due to its multi-system effects. Therefore, my take-home messages will be following. SGLT2 inhibition has fundamentally changes heart failure care. Across the ejection fraction spectrum, SGLT2 inhibitors consistently reduce cardiovascular deaths and heart failure hospitalization, with early and rapid benefit, including in the vulnerable post-discharge phase. SGLT2 works beyond glucose lowering. The benefits are driven by natriuresis, osmotic diuresis, improved myocardial energetics, reduced preload and afterload, modulation of NHE1, and favorable renal cardiac crosstalk. SGLT1 is biologically relevant in heart failure. Unlikely SGLT2 and SGLT1 is expressed in intestine, kidney, here we're talking about F3 segment, and importantly in cardiomyocytes, where it may influence sodium handling, intracellular calcium balance, and oxidative stress. SGLT1 is upregulating in failing myocardium. Dual SGLT1 and 2 inhibition expands the mechanistic scope by targeting both renal hemodynamics, here we're talking about SGLT2, and potential cardiac and intestinal pathways. And here we're talking about SGLT1. Dual inhibition offers a more comprehensive cardiometabolic approach. Also, clinical proof of concept already exists. In high-risk patients with diabetes and recent heart failure decompensation, dual inhibition demonstrated reduction in total cardiovascular deaths and heart failure events, including when initiated during or shortly after hospitalization. The future of a heart failure therapy is mechanism-guided, early, and spectrum-based. As we move into 2026 and beyond, the paradigm is no longer HFrEF only. The focus is early initiation in patient start when appropriate and treating across the heart failure continuum. And thank you for participating in this activity. Please continue to answer the questions that follow and complete the evaluation.
This program was presented by Medscape Education Global.